We have been discussing about the pancreatic surgery, and we have discussed about the pancreatic cancers, the congenital anomalies, which are basically related to the pancreas. And we have discussed the acute inflammatory conditions of the pancreas, specifically in the previous lecture, like we have discussed about the acute pancreatitis. There's another entity which is a chronic pancreatitis, and it's a kind of a chronic inflammation. And we all know that there's some kind of a difference in acute and the chronic inflammation. So it's a kind of a chronic inflammation in which there is extensive fibrosis of the pancreas, and ultimately it is affecting the exocrine and the endocrine function of the pancreas because of the extensive damage. So today we'll be talking about the chronic pancreatitis in our today's lecture, and how but first of all you should know what a chronic pancreatitis is actually. So the chronic pancreatitis is a chronic inflammatory progressive process in which there is damage to the normal pancreatic tissue, and there's fibrosis of the pancreatic acinar in the ductal cell, and ultimately there is insufficiency of the exocrine and the endocrine function. So there's some particular causes for the chronic pancreatitis. If you could see here particularly, so we divide this pancreatitis in the acute inflammatory process, and the other is basically the chronic inflammatory process. So we have been discussing the acute pancreatitis in the past lecture, but today our main focus will be about the chronic pancreatitis. So if we talk about the causes for the chronic pancreatitis, the most important cause is alcohol, and almost 70% of the cases of the chronic pancreatitis is because of the alcohol. But not all the people who are taking alcohol, but all those people, specifically those 5% of the population which is excessively taking alcohol in their diet and obviously in their daily routine, they develop the chronic pancreatitis. And if we talk about the causes of the pancreatitis, then there are a number of the causes, specifically like alcoholism, chronic alcoholism, then obviously the biliary obstruction secondarily to the stone. There can be hereditary pancreatitis, there can be autoimmune pancreatitis, there can be tropical pancreatitis. There can be pancreatitis because of the cystic fibrosis, which is the cystic fibrosis chronic pancreatitis. So the number of the causes, but always remember that almost 70% of the chronic pancreatitis develops because of the chronic alcoholism or because of the biliary obstruction. So like we have been discussing about the acute pancreatitis, so those patients in which the acute pancreatitis is not being resolved, and it actually built up into a chronic pancreatitis, and they have some recurrent attacks of acute pancreatitis along with the chronic pancreatitis, right? So say if you could appreciate in the diagram, is actually this is the cystic duct, this is a gallbladder, this is a cystic duct, and obviously this is the hepatic duct, and the hepatic duct and the cystic duct, they're combining together and they're making the common bile duct. This common bile duct along with the main pancreatic duct, and this is actually draining into the second part of the duodenum, right? But if there is obstruction in the, the confluence of both the ducts, or there is the stone which is being developed into this main pancreatic duct, then obviously it is going to cause the inflammatory process, and this then acute pancreatitis is actually converted into the chronic pancreatitis. And the most important hallmark for the chronic pancreatitis is that it actually there's extensive fibrosis, and ultimately with the passage of time this develops the exocrine and the endocrine insufficiency. And those patients who have the chronic pancreatitis for more than 20 years, there's a likely chance to develop a pancreatic carcinoma, because in the background of the chronic inflammation there's always a higher risk for the development of the cancer. So those people who have the chronic pancreatitis more than 20 years in their life, they live with that, and ultimately they develop a pancreatic cancer. So talking about the etiology of the chronic pancreatitis, I've already discussed that the main cause is alcoholism, and the chronic alcoholism basically, and almost 70% of the cases of the chronic pancreatitis are because of the alcoholism. But out of all the proportion taking the alcohol, only 5% of the people develop the chronic pancreatitis. Other causes are idiopathic, and some are related to the hereditary pancreatitis. Now, in hereditary pancreatitis, actually, there is a specific tyrosinogen activating enzymes, which are basically they're governed by some genes, which are PRSS1 and PRSS2 genes, which are located on the chromosome 7. So actually, in the hereditary pancreatitis, there's a mutation in the chromosome 7 affecting those particular genes, like the PRSS1 and the PRSS2 genes. So because of that, what happens is like there are some kind of the proteins which are called as a spin K1 and spin K2 proteins. So actually these proteins inhibit the effect of the trypsin and the trypsinogen. And we all know that these enzymes, particularly the pancreatic enzymes, they exocrine, they're most of the time they are autolytic in function, and if they are excessively they're present in their active form, then they start the auto digestion of the pancreas. So in the hereditary pancreatitis, actually there's a deficiency, there's a mutation in the genes in the segment on the chromosome 7, and most commonly the mutated genes involved are PRSS1 and the PRSS2 genes. So because of the mutations in that gene, that particular protein, like the spin K1 and the spin K2 proteins, they are not being synthesized, and they do not inhibit because they are not produced. So the effect of the trypsinogen is not inhibited actually. So because of the chronically activation of the trypsinogen, there's autodigestion of the pancreas, and because of this autodigestion, there is multiple development of the chronic fibrosis, and there's exocrine and endocrine insufficiency with the passage of time. So that's why the hereditary pancreatitis is actually developing the chronic pancreatitis. There's another pancreatitis which is called as tropical pancreatitis, and it's because of actually malnutrition, and all those countries which are malnourished and they are resource poor countries like southern India, like Kerala, like Africa, Asia, North America. So in all these countries, there is more likelihood of the malnutrition, and because of that, they develop the chronic pancreatitis, and this is particularly termed as a tropical pancreatitis because of it's developing in those particular areas, especially like the Africa, Asia, southern India, and the North America as well. Then there's another entity which is called as autoimmune pancreatitis, and actually in this autoimmune pancreatitis there are antibodies, and they are IgG4 subtype antibodies which are being produced, and they actually react with the antigens, and they start these antibodies, they are developed against the pancreatic tissue, and they start digesting the pancreatic substance, and because of that they develop the inflammation and ultimately the chronic pancreatitis. There's another important category which is called as a cystic fibrosis. And actually in the cystic fibrosis, it's a multi-organ disease which is not involving only the pancreatic system, but it's also involving the respiratory system, and also it's also involving the genitourinary system. So actually in the cystic fibrosis, there's deficiency, there's a mutation in the CFTR genes, and because of that mutation, there's some kind of the mutations in the chloride channels, and because of that the transport of the chloride is being affected, and that leads to the COPD, because in case of the respiratory system, there are kind of the mucus secretions, and because of the deficiency of the chloride channels and the CFTR mutations, those secretions are not being cleared up by the lungs, and ultimately the patient develop the COPD. Similarly, the patient develops the infertility in case of the cystic fibrosis, and in case of the pancreas particularly, they affect the exocrine function of the pancreas, and they develop the chronic pancreatitis. So other causes are obstructive. The obstruction may be secondarily to the stone, or maybe secondarily to the structure, because I've already told you that there is a cystic duct which is coming from the gallbladder, and there is the hepatic duct. And the common hepatic duct along with the cystic duct, they combine together and they actually make the common bile duct. And this common bile duct along with the main pancreatic duct, and they ultimately open into the second part of the duodenum. But sometimes if there's a stone in the gallbladder and it's actually slipped from the gallbladder into the common bile duct, and it's actually passing through the confluence of both the ducts, and maybe it is obstructed in the main pancreatic duct. So because of these obstruction, the remaining of the duct is dilated, main pancreatic duct is dilated, and there's a pooling of the secretion in the remaining of the pancreas, and it's actually because of the obstruction, there is a stasis of the secretion, and whenever there's a stasis of secretion, they ultimately develop the pancreatitis. So the obstruction can be secondarily to the stone or secondarily to the stricture, because ultimately, because of the chronic inflammation, there can be a stricture formation. And there's some particular group of the drugs, like the like the benzodiazepines, some kind of the antipsychotics, they also develop the chronic pancreatitis. So if we talk about the etiology, always remember that alcoholism, chronic alcoholism, is the main cause for the development of the chronic pancreatitis. And there are some other causes, which includes the obstruction, like secondarily to the biliary stone or secondarily to the structure formation. And the other causes are hereditary pancreatitis because of the mutations in the chromosome 7, which are actually affecting the PRSS1 and the PRSS2 genes, and ultimately affecting the inhibitory effect of this PNK1 and this PNK2 proteins on the trypsinogen, and that chronically activated trypsinogen effect on the pancreas. Then the other causes are the tropical, which are related to the southern India, Asian countries, malnourished, resource poor countries, North America, Africa, Asia, and Kerala as well. Then there are autoimmune causes related to the chronic pancreatitis because of the IgG4 subtype, which is actually acting against the pancreatic tissue and causing the destruction of the SNR and the ductal component of the pancreas. Then the other entity was cystic fibrosis. We have already discussed about the obstructive causes and some drugs like the benzodiazepines and antipsychotic drugs. So most commonly, you should remember the alcohol, and you should remember the obstructive causes like the biliary stone or the stricture. So now coming to the pathophysiology of the chronic pancreatitis, till now, there is no well-known risk or well-known mechanism, exact well-known mechanism for the development of the chronic pancreatitis. But there's some kind of the hypothesis which are still believed to be important in the development of the chronic pancreatitis. So actually, in case of the acute, on the background of the acute pancreatitis, either the inflammation will resolve and there would be generation of the healthy tissue, regeneration of the healthy tissue, or there would be, development of the chronic pancreatitis. So actually, this is the, in case of the acute inflammation, there's some kind of interleukins and the cytokines which are being produced, and the reactive oxygen species, they're actually causing the oxidative stress on the pancreas. So because of that oxidative stress, there is more of the lactic acidosis, there's more of the anaerobic respiration, and because of that, there is a development of the chronic pancreatitis. Plus, if we talk particularly about the alcohol, and if we talk about the tobacco smoking, as a result of alcohol and as a result of the tobacco smoke, there are some kind of the reactive oxygen species which are being produced, and they actually destruct the parenchyma of the pancreas, causing the chronic inflammation. Plus, in the metabolism of the alcohol or the tobacco smoke, ultimately there's some kind of the toxic metabolites, and these toxic metabolites, they actually act on the pancreatic cells, causing the SNR destruction. So one of the hypotheses in the patients of the chronic alcoholism or those which are habitual of tobacco smoke, so one of the mechanism is the production of the reactive oxidative species and toxic metabolite which are being produced, and they're affecting the pancreatic tissue. Plus, necrosis and the fibrosis. We all know that necrosis and the fibrosis, this is actually the hallmark of the chronic inflammation. So on the background of the acute pancreatitis, either it will resolve or there would be necrosis and the development of fibrosis as well. So on the background of the acute pancreatitis, actually, there's a development of the necrosis and extensive fibrosis, and ultimately, because of the replacement of the normal pancreatic tissue by the fibrotic tissue, obviously the function of the pancreas would be affected, and there would be replacement of the normal SNR and the ductal component by the fibrotic tissue. So obviously the fibrotic tissue would not be functional in nature, and if the patient will ultimately develop the exocrine and the endocrine insufficiency. There's another hypothesis, which is the SAPE hypothesis, and actually it's somehow related to the heredity and the autoimmune pancreatitis. Like I have already told you in the previous couple of slides, that actually, in case of the hereditary pancreatitis, there's some kind of the genes which are located on these chromosome 7, and they are particularly the PRSS1 and the PRSS2 genes, and they are actually meant for the production of particular proteins, which are the SpinK1 and the SpinK2 proteins. So they actually inhibit the effect of the trypsinogen on the pancreas. But if there's a mutation in those genes, particularly PRSS1 and the PRSS2, and there is a deficiency of the proteins like SpinK1 and SpinK2, then also the inhibitory effect of the trypsinogen would be compromised, and the trypsinogen will ultimately start auto-digestion of the pancreas, causing the chronic pancreatitis. So the same hypothesis actually explain the pathophysiology, particularly for the hereditary pancreatitis, on the basis of the mutations in the chromosome 7 and PRSS1 and the PRSS2 genes. Then there was stone and the duct obstruction. Okay, already very well explained, but I'm going to repeat it for you guys so that you can memorize it easily. Stone and the duct obstruction, and primarily they're the cholesterol stones which are developed in the gallbladder, because those people who are fatty, and particularly there's a high level of the lipids and the triglycerides in their body. So these actually cholesterol and the high triglycerides, they actually crystallize in the gallbladder and they develop the cholesterol related stones. So the stone can be slipped all the way from the gallbladder into the common bile duct and ultimately to the main pancreatic duct. And because of the obstruction in the main pancreatic duct, the remaining portion of the duct got dilated. There's stasis of the secretions. There's a pooling of the pancreatic secretions. And because of that, those enzymes, they start digesting their own pancreatic tissue, and obviously the result is a chronic pancreatitis. Then the large duct, obviously, the ductictasia. This is also another entity which is causing the chronic pancreatitis. But those patients who have got the pancreatic divisum or the annular pancreas, particularly in case of the annular pancreas, there is obstruction to the main pancreatic duct, right? Why? Because the annular pancreas, is like some part of the pancreas develops into the second part of the duodenum, right? And in the second part of the duodenum, there's an ampulla of the Vater, and that ampulla of the Vater is actually controlling the secretions coming from the common bile duct and the main pancreatic duct. So actually the annular pancreas causes blockage to the ampulla of the Vater, or there is ultimately a sphincter of the Edi dysfunction. So because of that, there is stasis of the secretions, and ultimately they develop a chronic pancreatitis. So far we had discussed about the etiology, and we've discussed about the pathophysiology. The important thing to remember is the chronic alcoholism and tobacco smoke, and because of that there's toxic metabolites, and because of that there's some reactive oxygen species which are being produced, and they target the pancreas and they cause extensive fibrosis and ultimately the chronic pancreatitis. Other than that, we have discussed the hereditary causes, and because of the mutations in some genes and affecting the inhibitory proteins, there's over functioning of the trypsinogen, and they start auto digestion of the pancreas, right? So if you could see here in this diagram, this is the histopathological slide of the pancreas, and it's actually showing the extensive fibrosis. As you can see here, almost all the glandular and the acinar the architecture of the pancreas is being destructed, and this is the stromal component, and you can see that the stromal component is more as compared to the glandular and the acinar component of the tissue. So actually, because of this extensive fibrosis, the main parenchymal tissue of the pancreas is affected, and in the histopathological evidence, there would be hallmarks for there would be necrosis, and there would be extensive fibrosis that will indicate the chronic pancreatitis. So, talking about the clinical features for the chronic pancreatitis, first presentation would be of pain, obviously. So the patient complains of the epigastric pain, but the location of the pain, that depends upon the area of the pancreatic tissue which is being involved. So the head of the pancreas is involved. Obviously the patient will complain more on the epigastric region and on the subcostal area. But if like the tail and the body of the pancreas is involved, then the patient will complain about the left subcostal pain or the pain of the left hypochondrium, and also radiating to the back. And if there is, usually the patient will give you the history that whenever I take the fatty things, I take more greasy intake, or the more food rich in the fats, I develop this pain. And the pain is usually a dull ache. But if the patient develop acute and chronic episode, then obviously the pain would be severe, and it would be associated with the nausea and the vomiting, right? So nausea is also not only the clinical feature of the acute pancreatitis, but also the chronic pancreatitis as well. Why? Because of that, there is, the patient will give you the history that I don't feel like eating, and whenever I try to eat something, I feel so much of the nauseated, right? So that would be the typical history. There would be the history of the weight loss, because in we all know that in the chronic inflammations there is a history of a weight loss, but actually, in particularly because in case of the chronic pancreatitis, what happens is like patient do not feel like eating, and his appetite is affected, and because of the because remaining hungry for a very long time, he developed loss of appetite, and because of that there is weight loss. Okay, and there is another clinical feature, which is the steroria. Now, because why this developed, because as the exocrine function of the pancreas would be affected, so obviously the process of the fat absorption and the fat digestion would be affected, and because of that there would be malabsorption of the fat, and there would be greasy stool that they were just particularly called as steroria. Now, when the endocrine part of the endocrine function of the pancreas is affected, then the patient will obviously develop the diabetes. So this was about the features for the chronic pancreatitis. Always remember that there would be pain, and the location of the pain that would that would depend on the area of the pancreas involved. At the head of the pancreas involved, the pain would be central and more on the right subcostal area. But if the patient has developed a chronic inflammation in the head, in the body or the tail of the pancreas, the pain would be more on the left side and on the back as well. Nausea, vomiting, if acute and chronic episode develops, and there would be weight loss, and there would be steroria, and there would be diabetes when the exocrine and the endocrine, both the functions of the pancreas is being compromised. So, talking about the investigation, initially, we actually divide the chronic pancreatitis into early stage and the late stage. So this increase in the serum amylase is usually, elevated in the early stages of the development of the chronic pancreatitis. In the acute pancreatitis, the serum amylase level, if there's increase in the threefold increase in the level of the serum amylase, and obviously that's the acute pancreatitis, and especially if there's a raise in the TLC count, and especially the differential neutrophilic count is increased. But in case of the chronic pancreatitis in the early stage, the TLC would be normal, but the lymphocyte count would be increased, and with the serum amylase level, they would be chronically elevated. So one is the baseline blood CP and the serum amylase level, then X-ray, because if there's a stricture, or if there's a stone in the duct, so the stone can be visible in case of the X-ray. The other investigation, the ultrasonography, but usually in case of the chronic pancreatitis, ultrasonography it will just tell you about the thickening of the pancreatic wall, but it won't be more helpful, and you cannot get a lot of information from the ultrasonography. The gold standard again here is a CT scan, but sometimes in case of the CT scan, it's difficult to appreciate a structure, so you always go for the MRI. But if we talk about the other things like MRCP, magnetic resonance cholangiopancreatography, and ERCP, because the whole of the tract, starting from the bile, cystic duct, and the gallbladder, common bile duct, the whole of the tract is being visualized. So MRCP and the ERCP, they're particularly very much helpful in making the diagnosis of the chronic pancreatitis. Plus, they also give you information in case of if there's a stricture, if there's a dilated main pancreatic duct, there's a stone, there's an increase in the wall thickness of the pancreas. So obviously that would, if there's a peripancreatic tissue, then obviously it will indicate about the acute inflammatory process, right? So MRI and the ERCP. But there's another endoscopic ultrasound, which is actually going to help you, just decide the if it's the early stage chronic pancreatitis or it's a late stage chronic pancreatitis, and obviously it will tell you about if there is a necrotic segment, and you will decide the type of the treatment or the type of the surgery you are going to perform in case of the chronic pancreatitis. So what you have to remember, start from the baseline investigation, go for the blood CP. The lymphocyte count would be increased in case of the chronic pancreatitis. Serum amylase level would be increased in the early stages, but in the late stages they remain usually normal. So if we talk about particularly if we talk about the investigation like the x-rays, if a stone is present, then that would be visible. CT scan is going to help you differentiate between acute and the chronic pancreatitis, obviously telling you about if there is peripancreatic fluid present or not. Then MRI, ERCP, MRCP, they're the best investigations for the chronic pancreatitis, and ERCP is both therapeutic and diagnostic. So if there is, in case of the chronic pancreatitis, there is the main problem is with the drainage. So you can just place the stent, keep the stent for 4 to 6 weeks for the drainage of the pancreatic fluid. So ERCP is therapeutic and diagnostic both, and obviously the endoscopic ultrasound, which is actually going to tell you about the, if there is a stricture, if there's a stone, if there's a dilatation, ductectasia, if there's a cyst or cyst, which is being present in the pancreas on the background of the acute pancreatitis. So you can see here in the diagram, this is the CT of the abdomen, particularly this is the liver, and you can see that this is the C-shaped curve of the duodenum, and just close to that, this is the main pancreatic tissue which is being present. And you can see here, just close to this arrow pointing out there in the middle, this is actually the stone which is present in the head of the pancreas. So obviously it will tell you, or there would be calcifications as well, right? So the calcifications are very much visible on the x-rays as well. And the calcifications are being also picked up by the CT scan. So there's a stone, and obviously there are microcalcifications which are present in case of the chronic pancreatitis. So this is the MRCP, and this you are visualizing the calcification, and this is the main pancreatic duct, and this main pancreatic duct is very much dilated, and there is a stricture, and there's a stone and a macrocalcification which is being present. So now, if you are done with the making up a diagnosis of the chronic pancreatitis, now obviously you need some kind of a treatment, and we divide the treatment in a medical treatment and obviously the surgical treatment. So if we talk about the medical treatment, the main, obviously, because in 70% of the chronic pancreatitis develops because of the chronic alcoholism, right? So you have to treat the addiction. How you are going to treat the addiction, you need some kind of rehabilitation specialist, you need psychologist, you need psychotherapist, and you have to give the patient a proper rehabilitation to treat the addiction. And you have to counsel the patient to stop the alcohol and tobacco. You have to admit the patient in a rehab department, and obviously you need a psychotherapist, and you need rehab specialist for that, and you need to involve the psychologist as well, right? In case of the medical treatment, the main focus is obviously to elevate the pain, right? So how you can do that, obviously most of the time the pain is because of the pooling of the secretions, and if you drain that fluid, pancreatic fluid, and if you drain that fluid by stenting or percutaneous or a transgastric aspiration, then obviously the pain will be alleviated. So you eliminate the obstructive factors, right? How you eliminate the obstructive factors, I've already told you. If there is ERCP, you have the facility of the endoscopic retrograde cholangiopancreatography. So along with that, you can just put the stent through the ERCP, or you can go for the transgastric or the percutaneous T-tube placement, obviously for the drainage of the fluid and obviously eliminate the obstructive factors. You can give a good analgesia, and you can escalate the analgesia in a stepwise fashion depending upon how severe is the pain of the patient. The main problem with a patient who have chronic pancreatitis is their professional life and their social life. They are badly affected. They're badly affected because of the pain and the discomfort they're always passing through. And whenever they eat something, they develop gnawing, and they develop adult-like pain. So because of that, their social life and their professional life is dramatically disturbed. So you have to give a good psychotherapy to the patient as well. You have to alleviate the stress factor as well. And obviously you can refer the patient to a good pain management specialist for the relief of the chronic pancreatitis. Plus, there's some kind of a block, especially if you block the celiac plexus. If we talk about the nerve supply of the pancreas, the celiac plexus is actually, there are nerves which are coming from the celiac plexus. And if we do the celiac plexus block in ultrasound or CT guided, then it's a kind of a good step in the pain management of the chronic pancreatitis. If we talk about the nutritional support, this is somehow very much important, because there's exocrine deficiency. Obviously, there would be deficiency of the vitamins. We know that there are two kinds of vitamins. One, they're not fat dependent, and other are fat soluble vitamins like A, E, D, K. So these vitamins are particularly, they are fat dependent, and because of the malabsorption of the fat, the vitamin deficiencies occur. So you have to give a good nutritional support. You have to give the patient a diet low in fat but high in the proteins and the carbohydrates. Plus, you have to combine the pancreatic enzymatic supplements with the meals. You have to correct the malabsorption. You have to correct the vitamins deficiency, and you have to give a vitamin B12 as well. And you have to put the patient on a micronutrient therapy as well. Then, talking about the pharmacological measures, you can put the patient on a steroid, and you can give, the medium chain triglycerides. They actually, they can be well absorbed. They can be very well absorbed, and even if there's a deficiency of the exocrine enzymes from the pancreas. So that's how you are going to treat a case of the chronic pancreatitis, rehabilitate the patient, stop the addiction, stop the alcohol, stop the tobacco use, give a good psychotherapy to the patient. This is somehow very much important to give a supportive therapy to the patient, restore the social and the professional life, alleviate the pain, put the patient on good analgesics, and escalate the analgesics slowly in a stepwise fashion, and refer the patient to a good pain management centers. And also the option can be a celiac block plexus. Plus, nutritional support is somehow very much important. Put the patient on a low fat diet, high protein and the carbohydrates. Give the supplemental pancreatic enzymes. Provide the patient with good vitamin supplementation, vitamin B12, micronutrient therapy, and pharmacological measures like putting the patient on steroids and medium chain triglyceride, and reducing the gastric secretions as well. Sometimes in the chronic pancreatitis I already developed, there's endocrine deficiency as well. So because of the destruction of the main bulk of the pancreatic tissue, there's endocrine deficiency, and the patient developed the diabetes. Then obviously you have to treat the diabetes as well. So what are the indications for the surgery when the patient is non-compliant to the medical therapy, or there is deterioration of the condition of the patient in spite of the medical therapy. Or there's some complication, like there is a stricture, there is a stone, there is a necrosis of the pancreas, then obviously you have to do the necrosectomy. Or there is biliary or the pancreatic stricture. Now, if there's a development of the duodenal stenosis, then obviously you have to go for the surgical options. If there's a development of the pancreatic fistula, there's a hemorrhage, there's a cyst, there's intractable chronic abdominal pain, formation of the pseudocyst, suspected pancreatic neoplasms, because in the background of the chronic pancreatitis there's always and if the pancreatitis is like more than for 20 years, then obviously there's a chance of development of the pancreatic neoplasm. So if there's a suspected pancreatic neoplasm, then obviously this is the indication for the surgery. Or the patient developed vascular complication. So you can put the patient on a medical therapy, but if all these things are present, then you have to go for the surgical options. If there's a biliary or the pancreatic stricture, there's a duodenal stenosis, there's a fistula, there's hemorrhage, intractable chronic abdominal pain, there's a formation of the pseudocyst, there's vascular complication, or there is a suspected pancreatic neoplasm, then you have to go for the surgical options, right? So what are the endoscopic and the surgical treatment? Obviously, when there's obstruction and there is a sphincter of the Oddi dysfunction or the obstruction to that, then obviously you do the endoscopic pancreatic sphincterotomy. Or if there is evidence of the stone, then you go for the ERCP with extracorporeal shock wave lithotripsy for the destruction of the stone. Or if there's a pseudocyst, then you go for the percutaneous drainage of the pseudocyst or the transgastric aspiration. You go for the Bagger-Ferry procedure for the correction of the stricture. You do the distal or the total pancreatectomy, right? So these were the treatment options for the chronic pancreatitis. If there is pseudocyst, then obviously you have to go for the ERCP guided stenting, or you have to go for the percutaneous or transgastric aspiration. Then for the stone, you have to combine the ERCP with the shockwave lithotripsy. Then if there's a problem with the sphincter, then you have to go for the endoscopic pancreatic sphincterotomy, or then you have to go for the distal or the total pancreatectomy. So if you could see here in the diagram how you put the endoscope through the mouth, and obviously you through the help of this endoscope you do the endoscopic pancreatic sphincterotomy, and obviously you open the sphincter of the Oddi. So because most of the time when there's obstruction or there's a chronic inflammation, there is sphincter of the Oddi dysfunction, or for the drainage, you do the sphincterotomy. You do the extracorporeal shockwave lithotripsy for the destruction of the stone, as you can see in the picture here. That this is actually the stone, and you put this endoscope here, and by the help of this endoscope, you do the extracorporeal shockwave lithotripsy, and you destruct the stone, as you can see here in the diagram as well. Like this was the stone, so that this was being destructed by the extracorporeal shockwave lithotripsy. Now, if we particularly talk about the main surgical options we can do for the pancreaticoduodenectomy, or you can go for the pancreaticoduodenostomy, right? So this is a very simple procedure. It's not that much complicated. What you do is you remove the pancreatic tissue. Then this is the jejunal loop. This is the duodenal loop. So what you do is you do the anastomosis, right? So actually, this is the duodenum, and you do the duodenojejunectomy or the duodenojejunal anastomosis. And you also, one part of the jejunum, after the removal of the the necrotic or pancreatic tissue, or the distal pancreas or the proximal, depending upon where the lesion was. So you actually do the pancreatic ooginostomy. This is the loop of the jejunum, which is being anastomosed with the remaining part of the pancreas. So the treatment options for that is like pancreatic ooginoectomy. You remove a portion of the pancreas along with the duodenum, and obviously the remaining portion of the duodenum is combined with the jejunum, which is the duodenojejunectomy, or you do the pancreatic ooginostomy in case of the if the smaller portion of the distal portion of the pancreas is being removed. The other option is a pancreatectomy, in which total pancreatectomy is the option. So particularly what you're going to do in a pancreatectomy is like you have to remove the whole of the portion of the pancreas along with the some part of the duodenum, or some part of the antrum as well, particularly the stomach antrum. But there's some surgeries which involve the duodenum preserving pancreatectomy, in which obviously the duodenum is being preserved and a bypass is created between the stomach and the jejunum. So you do the gastrojejunectomy, or you do the gastroduodenostomy or duodenojejunectomy, depending upon how much of the resection you have done, or depending upon the level of the resection you have done. So you can see here in the diagram, as actually this is the cutoff point, like the gastric antrum, the pylorus is actually being removed, or it's some part of the duodenum along with the pancreas, and you do the gastroduodenostomy or gastrojejunectomy. Like it's a kind of bypass procedure if there's obstruction and you're unable to remove the duodenum or the distal part of the bile duct. Then you actually do the duodenum preserving with surgery, in which actually you only remove the pancreatic tissue along with the stomach, and you do the gastrojejunectomy or the gastroduodenostomy. So that's all for today's lecture. So we have discussed the causes of the chronic pancreatitis. We discussed about the investigations we have available to diagnose case of the chronic pancreatitis, what kind of a medical therapy should be given to the patient, like the psychosupportive therapy, especially the rehab part, and how to alleviate the pain of such patients, and what are the indications of the surgery, and what are the treatment options, especially the treatment procedures indicating like the duodenum preserving surgery and the total pancreatectomy. So that's all for today. Thank you for watching sqadia.com.